Kelly, you may begin our webinar.
Welcome to this ACI Alliance Tuesday Talk. This webinar is being recorded. Kit and I are your co-hosts today. My name's Kelly Flodine. I grew up hearing pretty good, but slowly lost my hearing due to some bad genetics and just living a stupidly loud life. My hearing aids finally were not getting the job done anymore. And thankfully, I was referred for CI evaluation and bilaterally implanted at MUSC here in Charleston, South Carolina in 2020. My CIs have been a life-changing intervention for me. I'm back to living my life as I know it in a hearing world. It feels good to advocate for something that has had such a profound impact on my life. And I appreciate the effort the ACI Alliance puts into getting the message out to the masses and for letting me be a part of the things here today. This talk is part of an ongoing series for parents, adults with hearing loss, family members, and others. As members of the ACI Alliance's Consumer Advocacy Network, the CI Can, we hope that you can learn from this session and consider getting involved in the work of the ACI Alliance. Slide 2.
Hi, this is Kit Mohan here. I live in Redmond, Washington, and after wearing progressively more powerful hearing aids over the last 20 years or so, I decided to get a cochlear implant in May of last year. So I'm a relatively recent implantee. This has been a real game changer for me. And now I can follow conversations. I can hear birds on the golf course. I can hear the microwave beep and turn signals in the car and other sounds that I could not hear before, even with my hearing aids. I'm a big believer in this technology. So as we get started, first, let's review the technology. Let's go over the Zoom settings. That'll help you to access closed captioning. I used to do that a lot when I was on Zoom before my cochlear implant. You first click the settings in the navigation panel at the top of the screen. Then under the Meetings tab, verify that the closed captioning is enabled. And if it is not, then you can just toggle it to enable it. And also, if you want to ask a question, please use the chat box and type it in, and we will get you an answer. Next slide, please.
The American Cochlear Implant Alliance is a unique organization that's focused on cochlear implants across the care continuum. We were founded because it was felt that cochlear implants fall through the cracks at other hearing health organizations. We want to focus attention just on improving access to CIs. The mission of the ACI Alliance is to support the research, advance awareness, and advocacy. Slide 4.
CI Can. CAN stands for Consumer Advocacy Network. This is a network for adult consumers and family members of recipients, including parents, of course, aimed at enhancing and enlarging the broader advocacy efforts with firsthand knowledge of cochlear implants. So personal stories make the difference in impacting decision makers, and it adds credibility in our contacts with state and federal representatives on key issues. If you're interested in learning more about CI Can, please let us know in the chat box, and the ACI Alliance staff will follow up with you later. Next slide, please.
We also wanted to share a few of the ACI Alliance's website resources that are available, as we see here on slide 5. Slide 6, please.
And now I'm delighted and honored to introduce Dr. Daniel Zeitler of Virginia Mason Hospital here in Seattle. He is the speaker today, but before I begin to read his bio, I wanted to tell you that he was my implant surgeon. And he is a very caring and compassionate person who patiently addressed all of my questions and concerns beforehand. And with that, I'm delighted to introduce our featured speaker today, Dr. Daniel Zeitler. Next slide, please.
Well, very good. Kit, it's wonderful to see you again. I'm so thrilled to be introduced by one of my star performers. Kelly, it's fantastic to meet you today, and I appreciate the advocacy and the awareness that you are giving all of those people out there in similar positions with hearing loss. So my job today is going to be to talk to everybody here about what to expect at the time of your cochlear implant surgery. This is probably the part that is most anxiety provoking. It's the part that probably is sort of the black box of the process. And hopefully I can shed some light on some of that mysterious stuff that we do in the operating theater. Before I get to that, I do want to talk about why cochlear implantation is so important, because as we all know, many people can use hearing aids very successfully, but the WHO, or the World Health Organization, has given some quite scary projections where they show that people with disabling hearing loss worldwide is going to rise from about 460 million, where we are today, to almost 1 billion people by the year 2050. So these are people with disabling hearing loss. These are people who may or may not even be able to benefit from their hearing aids. And that's why it's vitally important that we all understand that cochlear implantation is the option that you have, much like Kelly and Kit, when you get to the point where hearing aids don't work.
Dr. Zeitler, if I may, I'm sure most of the people on the call probably don't know as much about you as I do. So if I may take just a minute to read some of your background.
Sure.
So Dr. Zeitler, he's an MD FACS. He's a fellowship-trained neurotologist at Virginia Mason Medical Center in Seattle, Washington, where he serves as co-director of the Listen for Life Cochlear Implant Center and clinical facility at the University of Washington Department of Otolaryngology. He earned his medical degree from New York University of Medicine. I think that is one of the reasons why I was drawn to him, because my wife and I have lived on the East Coast most of the time. And he completed his general surgery internship and residency in otolaryngology, head and neck surgery at New York University Medical Center, Bellevue Hospital. He then completed his fellowship in otology, neurotology at the University of Miami Ear Institute. Dr. Zeitler has been awarded numerous research chairs as Virginia Mason for his work investigating cochlear implant outcomes, cochlear implantation for single-sided deafness, and using artificial intelligence to predict outcomes following cochlear implant surgery. He has authored over 50 peer-reviewed articles, numerous book chapters, and he remains active in the American Academy of Otolaryngology, Head and Neck Surgery, and the American Neurotology Society. He serves on the board of directors for the American Cochlear Implant Alliance and on the medical advisory of the Acoustic Neuroma Association. Dr. Zeitler, back to you.
Sorry, I get so excited to talk about implantation that I spoke out of turn. So thank you for that additional kind introduction. It's also becoming apparent, not only are the rates of disabling hearing loss rising around the world, but no part of the world is immune to the effects of hearing loss. And as you can see here on this map, every single area of our world shows similarly scary rates of rise of disabling hearing loss. I think it's also important as a cochlear implant surgeon for you all to understand what I have to do. And what that is to make sure that I treat my job as a learning process. I love this chart by Adam Grant in his book, Think Again. If I say that I'm always right, I'm essentially a cult leader, and no one wants to have their surgery with a cult leader. As I learn that they're wrong, but we're right, I become a politician. If everybody's wrong, I'm a contrarian. But then I sort of get into that, well, that might be wrong. And now I'm critically thinking. And then I get to the point where I might be wrong. And that's where I become a learner. And I think it's very, very important to understand that the world of cochlear implantation, even in the 2 decades that I've been doing this, has changed so substantially that if I'm not willing to change, then I'm going to be left behind in a technology storm that will not only do disservice to my patients, but it will do disservice to the way that I practice medicine. And I think that we as ENT doctors are doing things the right way. This is a really interesting, quite comical graph that shows the number of swear words used in the operating room by a number of specialties. And as you can see here, on the left side of the graph, our ear, nose, and throat, you can see that we had by far the most, the third most operating time at 655 minutes, but we only got 2 swear points. So we did quite well compared to the orthopedic surgeons and the general surgeons. So we are learning, but also remaining relatively non-frustrated in the operating room. So I think we're the best of both worlds. So you can expect that your ENT surgeon will not be swearing while you're under general anesthesia. It's also very important to remember that I, as the implant surgeon, am just the guy who threads the string through the needle hole. And I like to tell my patients, my job is probably the sexiest, but it's certainly not the hardest. I think the patient has the hardest job learning to use their implant. I think the audiologist has the second hardest job, making sure the patient can and knows how to use their implant. And so even though I thread the needle, we all work together to make these beautiful tapestries of hearing. And so it's important that I recognize all of my colleagues and my patients who have put in the time and energy to make these machines, which are miraculous, work efficiently. It's also similarly important to understand that we do work as a team. So, we have the medical side of things, which is me. We have the audiologist and the audiogram. We have to understand that there's a hearing history that's important to consider. How did the patient lose their hearing and why? When? How long have they been wearing hearing aids? Have the hearing aids been effective? What is their lifestyle, right? Kelly was just telling me this morning, he's a water skier. Kit is a golfer. That tells me some things that I need to know about what are their expectations for success. What will they consider good outcomes? And what do they want to make sure they can still do with their implants that they did before they got surgery? So these are all important things which ultimately place the candidate at the middle. And that's what we all have to remember. So what are the steps to getting a cochlear implant? Well, the Tuesday talks have touched on a number of these things. So we're going to focus really on a few things today. But first, you have to find a center. And luckily, the American Cochlear Implant Alliance can help you do that quite easily. If you go to their website and you click on your state, you can find a center near you. Remember, these are centers that are enrolled in the American Cochlear Implant Alliance, so there very well may be other centers close to you, but these are certainly the ones that we can vouch for because they have been vetted by our organization. And today we're specifically going to talk about the medical evaluation and the surgery itself. The medical evaluation, I like to say, is often complex and occasionally straightforward. And I think that as people come in now with increasing amounts of residual hearing, as people are getting older and needing implants, these things are becoming even less straightforward because now we have patients who 10, 15, 20 years ago weren't cochlear implant candidates, and now they are. We talked about there has to be a multidisciplinary team, which necessarily is composed of a surgeon and a cochlear implant audiologist. But there might be others. There may be a speech and language pathologist. There might be a neuropsychologist. There might be a radiologist or a neuroradiologist if we have questions about what we're looking at on scans. So this is a small team that is very quickly enlarged based on the needs and indications. The candidate must also, though, possess a significant motivation to rehabilitate not only their hearing, but their quality of life. Most of the people that we have come in the clinic want to hear better, not because their wife tells them or their husband tells them that they want to hear better, but because they themselves want to hear better. They want to be able to hear the things that they used to hear 20, 30 years ago. So it's very important that they possess that motivation. It's also vitally important. One of the biggest questions I get all the time is, well, aren't I too old for a cochlear implant surgeon? And the answer is almost always no. There are a couple of people that are too old. My oldest patient to date is 99. So you're never too old. But certainly we know that as we age, cognitive status changes. We know that our psychosocial status changes. We have different demands on our social life. We have fine motor skill changes, right? So our hands, our fingers become a little less nimble than they used to be, and maybe you have a harder time getting the equipment on and functioning. And we also know that there are changes in receptive and expressive language that have to be considered. But as I said, there are many, many successful octogenarians and nonagenarians who have been implanted by both myself and my colleagues. And there are a number of articles to prove that. I'm not going to go through these in depth, but you can see a number of articles looking at elderly patients undergoing cochlear implantation very successfully with minimal anesthetic risk. So the first step when you come into my clinic is to perform a thorough medical evaluation. We go over your general health status. What are your other medical comorbidities or other medical problems that you might be suffering from? We certainly take a thorough otologic history. We do a neuro-otologic history. So we look through the microscope at your ears. We want to make sure that we review very closely your audiometric testing and any other audiogram or hearing testing that you've had in the past. We also always talk about balance problems. We know that about a third of adults who are over the age of 40 can have some vestibular dysfunction or balance dysfunction. And it's important for us to understand this. On rare occasions, we may even be able to make a decision, as we'll talk a little bit, about which ear to implant if one of the ears has less or more balance function than the other. It's for these reasons that some people actually advocate formal vestibular testing prior to cochlear implant surgery. There is certainly no uniformity in those recommendations. In my clinic, I do not obtain balance testing routinely, but certainly use use my discretion for when it might be helpful or necessary, but it is by no means required. And perhaps at the end of this, Kit and Kelly, if they have insight on balance testing or balance problems, I'd love to hear their insights. Chronic disease is not a contraindication. In other words, we have plenty of patients who are diabetics, who have kidney disease, who have cardiac disease, go very successfully into cochlear implant surgery, but we do engage their care team, whether that's a primary care doctor or a cardiologist. Perhaps they have a geriatrician who monitors their medications. We oftentimes have people who need preoperative cardiac clearance, whether that's in the form of an electrocardiogram or even a formal stress test. Again, many of our patients are getting older and some of them have heart disease. Some of them maybe even have had bypass in the past. So these are all things that we need to think about, but certainly it is not a reason to fear surgery because we know that outpatient surgery for cochlear implantation is very safe. Many of these are done in ambulatory surgery centers where there's not even an attached hospital. And in rare occasions, we can even give local anesthesia. So if a patient's doctor says, look, I just can't feel comfortable with general anesthesia, we can actually anesthetize them and give them kind of the type of anesthesia you might get for a colonoscopy or dentist, where you're kind of dazed and confused, but not necessarily anesthetized. And I actually have I've done a couple of these, and just as an aside, one of my favorite stories of my cochlear implant career thus far is I did a patient with local anesthesia, and when they came in for the post-operative checkup, I said, so how was that? And they said, well, the surgery was fine, but the strangest thing, I could actually hear the electrode going into my cochlea as you did the insertion. And so that totally blew my mind. And not that I want to do it all the time, but I loved hearing that story. As far as imaging requirements are concerned, there is some clinical disagreement about when and what tests to get. I tend to be fairly aggressive about getting imaging. We do have residents that operate with us. So I use the imaging to go over anatomy with the residents. I like to have it present so I know what to expect anatomically. We typically get a temporal bone CAT scan, which is an easy test. It's quickly acquired. It takes about 4 or 5 minutes to get. We do have the ability and oftentimes do get an MRI in patients who may have other neurological diseases, such as headaches or Meniere's disease, multiple sclerosis, things where we might want to check their central nervous system. In cases of meningitis, we oftentimes get both a CAT scan and an MRI because a CAT scan and an MRI are sort of collaborative in the information they can give us, and I'll show you an example of that. In patients who have asymmetric hearing loss, so we're implanting more and more patients with one good ear and one bad ear. In fact, the extreme of that is single-sided deafness, which is now approved by the FDA for cochlear implantation. So in these patients, we definitely want to get an MRI, which allows us to make sure that they don't have a tumor or other anatomic reason for their significant asymmetry. But a lot of this discussion is a bit outdated because in the past, we used to say, well, if they have other neurological symptoms, we better get an MRI now because once the implant is in, as you know, there's a magnet and you can no longer get an MRI. Well, the newest generation implants for all 3 of the FDA-approved cochlear implant companies now have MRI-compatible magnets. So this has become a moot point and really is no longer a consideration. But what I think is most interesting, because I want to make sure that if you do go see your surgeon and they don't order a test, you should not worry, because if you take a postlingually deaf or a person who is deafened after they learn to speak, they have a normal exam, their history is relatively unremarkable, and their hearing loss is symmetric, that imaging test that they're going to get will change what they do in less than 2 out of 100 patients. So there are cochlear implant surgeons out there, and I know some of them who choose not to get any testing preoperatively. And so do not fear if your surgeon does not do that. I am sure he or she knows what they're doing. This is just an example of what a CAT scan might show us. So here is the cochlea on the right side, and you can see that this tube is widely patent. You can see that it's full of gray, which is the fluid of the cochlear duct. That's where we're going to put the electrode. Here on the left side, you can see that that same area is open in the far end, but more closely related to the area of insertion. You can see there's some bony growth here. And this is what can happen in a case of meningitis. And this is something that we absolutely want to know ahead of time, because this is a patient who you may have to slightly change your approach, or maybe even have to change the place where you put the electrode itself. This is a similar MRI, and you can see the arrows here on the right side. You can see that this white streak is the fluid of the cochlea, and it's nicely wide and open. And here you can see that streak of fluid is not only much narrower, but it's much darker. And this is a patient, again, who's had meningitis. And this is a cochlea that's been compromised by the meningitis. And again, something we'd want to know ahead of time. Does not preclude implantation whatsoever, but it does create some subtleties for the surgeon that they would want to know ahead of time. There are almost no people that cannot get a cochlear implant. This is a short list. Certainly we know that if you don't have a cochlea or you don't have a hearing nerve, then you cannot get a cochlear implant, almost by definition. There are some people who, in young children who have an absence of a cochlear nerve, will still try to put in a cochlear implant as a last resort before they move on to more invasive things. This is incredibly rare. in an adult, right? Because in an adult who's learned to talk and who has had hearing, we know that they have a nerve. People that lose hearing loss, it's almost never because there's been damage to the nerve. It's typically damage to the cochlea. So people often ask, well, how can I get a cochlear implant if I'm deaf? And the answer is the implant bypasses the most common site of disease. Certainly, there are people who have medical issues that preclude implantation. Certainly, people who we test and find that the hearing aid works better than what we might expect the implant to do. And then lastly, and I put it in red because to me, this is the most important, if a patient doesn't want surgery, they shouldn't get surgery. To me, that's an absolute reason not to do it. Again, we have to have people who are willing to change their quality of life because as the two moderators and anybody else will tell you, the surgery is the first part of a long journey and it requires a lot of time, a lot of energy, a lot of commitment. And if you're not willing to commit to that, then it's going to be a bad outcome. And we know that from data and we know that from anecdotal experience. And there are a number of other things here that you can see are relative contraindications. These mean that you can do cochlear implantation, but you just have to be a little bit careful and have discussions about expectations and potential outcomes. So I will not read through those, but you can see them there. Again, I highlight extremes of age. Cochlear implants now are indicated in kids at 9 months and older. Some of us are implanting children even younger than 9 months. And again, my oldest is 99. I think that's, believe it or not terribly unusual. I think if you ask around, most of us will tell you one of our patients is in their late 90s. There's been a swing of the pendulum in how we determine which ear to implant. So historically, in the sort of the late 90s, early 2000s, the dogma was always implant the deafer ear. And the thought was if you implant the deafer ear, the patient can then still continue to benefit from the ear that they believe and they test to be better. We are now learning that that dogma is substantially outdated and probably incorrect some of the time, because we know now from data and also from, again, anecdotal experience, that it's the better ear that's not only preferred by the patient sometimes, but will perform the best. And so in addition to the audiogram, we also have to take into account patient preference. I have a truck driver who, for instance, always had his passenger on the right side, and he specifically wanted his right ear implanted, even though his right ear was slightly better, because that's the side his passengers sit on. And that's, again, taking into account his quality of life and his demands and his needs. So that's just one example that comes to mind. So we really do have to think about this in a much broader scope. And this is a very, very basic and should not be considered dogma chart that I made. But the first thing that we kind of think about is medical. So do you have something abnormal in your medical exam? If yes, maybe you've had a tumor, maybe you've had previous surgery on your worse ear. So maybe that leads us to want to implant the better ear. If your medical history is normal, but you have something abnormal on your imaging, so maybe we see some changes in your cochlea in your worse ear, maybe that drives us to implant the better ear. If all of that's normal, but you have an ear that's been deaf for 50 years or 60 years, we know that even though it can be implanted, the expectations have to be pretty low for an ear that's been deaf that long. So maybe that makes us want to implant the better ear. But if all of these things are normal and you have both hearing ears that are relatively the same, they've been deaf the same amount of time, in that case, we do tend to implant the worse ear. Now, in some people, they end up getting both ears implanted, and I always tell my patients they're my happiest patients because then we know we implanted the better ear. So, but at the same time, we don't implant both ears just because we want to make sure that the second ear is still a candidate for implantation after the first one has been implanted. What's interesting is if you take all of these things that we as the surgeons think are important, the age at the time of deafness, the duration of deafness, how old they are, did they use a hearing aid or not, how they got their hearing loss, if we sort of put all those in a mixing bowl and smush them together, all of that only accounts for less than a quarter of the variation in performance of our patients. So we think we know what we're doing, but the answer is we don't really know what we're doing, because ultimately 3/4 of this is determined by stuff we can't measure, whether it's in the brain, whether it's inside the cochlea, we just don't know. But what we do know is that the better versus worse ear is not part of this 22%. So again, just to sort of highlight the importance that the ear decision has to be one that is truly shared decision making, and there should not be dogma about that. Your surgeon may ask that you have cognitive testing. This is becoming increasingly popular in the last few years. There is no real standard protocol on how to do this. There's no real standard number at which point we would say you can or cannot have an implant. And there's no real test that has shown to be predictive specifically of postoperative outcomes. You may have somebody recommend you take something called the Montreal Cognitive Assessment, or MoCA. You may be asked to take the Mini Mental Status Exam, or MSSE. There are many others. And again, some of these may be done by centers who are just simply collecting data. They may not be making a statement about your cognitive status. They may just be collecting data. But if your surgeon does talk to you about this, you should ask them the purpose of the testing. We do know that there is a fairly deeply woven link between dementia and hearing loss. And what's interesting is some people who seem demented on first evaluation become highly, or I should say, much more increasingly cognitively intact after their implant, because what we've actually done is fix their hearing loss, and that was a big cause of what seemed to be their memory loss. There is growing evidence that communication and speech recognition outcomes can be influenced by cognitive ability. So this is really why we're becoming increasingly aware of this. And again, maybe screening tool, maybe a counseling tool. If you're someone sort of right on the borderline of whether to or to not get an implant, but you have some significant dementia, this may be something that helps tip the scale one way or the other. Of course, everybody always wants to know what are the complications. The good news for all of you and for all of us doing these surgeries is that the rates of complications have decreased substantially over the last 20 or 30 years. This is a list of things that could possibly go wrong, and we'll highlight a few of these in the following slides. But remember, some of these things that are considered complications really are not complications. So tinnitus gets considered a complication. Device failure, which we'll talk about, which obviously is out of the hands of the surgeon, can be considered a complication. Dizziness, which is something that can happen to a percentage of people, which we'll talk about. So again, some of these are called complications, but really the severe complications occur in less than 2% of people. What's interesting here, I highlighted with these asterisks, is now that we are having increasingly bigger and bigger amounts of hearing left in the ear that we're putting the implant in, as the criteria broaden, some people consider hearing loss in the implant ear a complication. And I think we could respectfully argue about whether that's a true complication or not. But what's interesting is that in the big centers who have really looked at this with their data, ourselves included, the rates of retaining some amount of hearing in the implanted ear are probably in the neighborhood of 50 to 70%. So there's a better than coin flips chance that you could have some hearing left in your implant ear, which has allowed many patients with an implant to use something called electric plus acoustic hearing, where they actually use a hearing aid and the implant on the same side. And this is something that could be discussed with your surgeon. So let's talk about device failure. So remember, these devices, while miraculous, are at the end of the day computers. They're small computers in your head, and they do rely on electronics, and electronics can fail. As we all know with our iPhones and with everything else, And so what they've done is they can look at these through something called a Kaplan-Meier survival curve. And what this basically does is it takes whatever you're looking at, whether it's heart attack or cochlear implant failure or the risk of cancer, and it looks at that risk over time. And you'll see these curves in a lot of different things in medicine. So if you take these Kaplan-Meier curves, you can look at device failure two different ways. You can look at what's called cumulative device survival, which means you take 100 devices and you look at them over at a 10-year point and you say how many of those devices are still alive. You can also look at device-specific survival, which basically says I'm going to take 100 devices and follow those specific 100 devices for 10 years. So it's a little different way of looking at the same thing, which is the likelihood that your implant will be alive at 10 years. And you can see that anywhere between 94 and 100% of these implants at 10 years are still functional. So patients always ask, what's the likelihood that I need this replaced in my lifetime? And I say that they're probably made to get a good 30 or 40 years. So for our 50 to 60-year-olds, that should be the last time you have the surgery. That being said, we do know that there are device failures and they're unavoidable, but the good news is they're easily fixable. Easily for me, unfortunately, it means a second surgery for the patient, but it is certainly not the end of your opportunity to use your implant. The risks in children are almost identical, maybe slightly lower, but we know that children have much higher rates of head trauma, and that is probably what accounts for those differences. We briefly touched on balance function after surgery. So we know that about half of patients will report some transient or temporary vertigo. Most often there are reports that it starts a day or two after surgery. And what's interesting, we don't really know why this is. Theoretically, the cochlea is connected to the balance system of the inner ear, but they're anatomically distinct. So we don't know whether it's the action of putting the electrode into the cochlea. We don't know whether it's the anesthesia. We just don't know. But we've tried to study this, and we've run into some some dead ends because nothing seems to really correlate with anything else. What's interesting is that a third of patients will show reduced function on a vestibular test, but they will not complain of anything on their dizziness handicap. So some patients are dizzy, but don't have tests that show it. Some patients have tests that show dysfunction, but aren't dizzy. So you go figure this out, because I certainly can't. What's the good news is that almost nobody has permanent vestibular damage. Almost nobody has permanent balance problems. The one that obviously scares most people, and certainly surgeons included, is damage to the facial nerve. So the facial nerve is one of the cranial nerves that comes off of the brainstem. It travels through the mastoid bone behind your ear where we drill, which I'll show you. So that nerve is at the scene of the crime, so to speak. We do our very, very best to avoid damaging that nerve. And the good news is that in adults with normal anatomy, that nerve is in the same place every time. So we know exactly where to look for it. We do use intraoperative monitoring, or most of us use intraoperative monitoring. So if we get close to that nerve, we have a little thing that beeps that tells us we're banging it or pushing it, and we move away, step away, as they say. But we do know that there is a small percentage that can have some transient or temporary injury to that nerve. We think of it kind of like a Bell's palsy. It'll typically start 24 to 48 hours after surgery. We think it could be due to reactivation of some viruses in that nerve due to the trauma. It could be the heat from the microscope or the drill. But at the end of the day, we don't really know. Only a fraction of that fraction will have incomplete recovery. So 99% of patients, if they were to get Bell's palsy, will recover completely. But the risk of a permanent injury to the facial nerve is less than 1 in 1,000. It's probably 1 in 10,000 in the hands of a surgeon who knows what they're doing. Again, a good reason to use the ACI Alliance's map to find your closest surgeon. We know also that the risk of meningitis exists. For Kit and Kelly, they can tell you, but we do recommend all of our patients have a meningitis vaccine. It is not required, but it is highly recommended because it is also suggested by the CDC. This is probably more of a historical issue than anything, but it has to do with some modifications that we did to the electrodes, to the way that we perform our surgery. There are very few cases worldwide, about 20 per year, and the CDC suggests that children are probably at higher risk, and we can talk if we want to about why that is, but suffice it to say, the vaccine is certainly a good idea. There's very little downside, but the risk is probably also very low. And this is just a chart, since this is going to be online, you can reference it at your convenience of the vaccine recommendations. So let's end with a little discussion about surgery. These are some of the myths that I think are important to bust, because the patients oftentimes will hear very strange, very inaccurate details about how surgery for cochlear implantation actually happens. I want to reinforce this is not brain surgery. On a good day during cochlear implant surgery, I will not see your brain. We do this in an outpatient setting, typically in an ambulatory surgery center. The pain is typically mild. Most of our patients get by with just over-the-counter medication postoperatively. I typically don't shave any hair, and if I do, it's a small amount. We do use general anesthesia. The surgery is about a 60-minute to 80-minute operation. We talked about monitoring your facial nerve to prevent any damage. Some centers will perform some testing on the device intraoperatively just to make sure that it's functional out of the box. There is a very small out-of-box failure rate. Other centers will perform an X-ray to confirm placement. Some centers do both, some centers do neither, some centers do one or the other. Again, something to discuss with your surgeon. And again, we talked about complications being very rare. This is a patient who had an implant done about 20 years ago. You can see she got a very nice haircut, or maybe not very nice, depending on who you ask. You can see our incision was about the size of a garden hose. And after surgery, you can see there's a big incision with a lot of staples. This is the old way. The new way now is I make a 3.5 to 4 centimeter incision right behind the ear. You can see here the hair is taped back. I haven't even had to shave any of this person's hair. And when you fold the ear back, that incision is beautifully hidden in the crease. These are some cartoons about sort of the anatomy that we'll find. So we drill the mastoid bone here, this cavity. Here you can see one of the small bones of hearing called the incus or the anvil. This white line is going to be the facial nerve. Again, this is my biggest job during surgery, is to avoid damaging this nerve. We go between the facial nerve, which is here, and the chordotympany nerve. This nerve controls, controls taste. So some people after surgery will complain that they have a metallic taste or kind of a numbness to their taste. And that's because this nerve sometimes can also get heated up or traumatized. And this space between those two nerves is about 1.5 to 2 millimeters. So this is where we are going to enter into the middle ear. And there, once we open this space, we can see the cochlea. Here's the cochlea. This is the round window. Most of our implants now are being put through the round window, which allows us to know that the placement is in the exact correct spot. This is a beautiful video that I've used with permission from Advanced Bionics. And you can see here the implant coming in at the top of the screen. The top of the roof of the cochlea has been drilled off. So you can see the implant coming in. Here it's sliding in, it hits the outer wall. And you can see that as it goes in, it curls around this shell-shaped spiral. So again, as this goes in, as the surgeon, all I'm seeing is this area right here. All of this that's happening beyond that is blind to me. So we feed it very slowly and very deliberately, so we make sure that it doesn't cause any trauma, undue trauma inside the inner ear. This is a beautiful histologic section of a cochlear implant that's been dissected out of a cochlea. And here you can see the implant with all of its electrical wires. And this is the lumen, or the tube of the cochlea. And as you remember, it's a spiral. So as it goes up, we can see that the implant is all the way up here at the top of the cochlea. This is what we want to see when we're all done. You can see this implant going in and taking this beautiful spiral around the cochlea. This patient actually was one of my patients who had a second implant. So he was incredibly happy. And this is the incision when we're all done. We use dissolvable stitches, and I put some skin glue on the top so our patients can take a shower the day after surgery. And again, that's what the ear looks like folded back. Some patients come in and literally can't even see their incision. So no visible stitches. We do have them wear a dressing for 24 hours. We ask that they stop any blood thinners for 24 hours, but there are some patients whose doctors don't feel comfortable stopping their blood thinners, so we will allow them to continue it. Because we use the skin glue, they can take a shower in about 24 hours. They typically return to normal activity in less than 3 days, depending on what they like to do. We ask that they not lift anything heavy for about 10 days. And some of my patients who come from a distance are allowed to get back on their plane the next day to go home. So thank you very much. I guess I'll turn it back over to our wonderful moderators.
Thank you very much, Daniel. That's going to be a good resource for candidates in the future, I'm sure. There's a little group of candidates I try to keep in touch with, and that's one of the things that they always say is, what should I ask my surgeon when I'm going in for consultation? So this is going to be a good reference for that.
We've got a couple of questions, but if I may, I had a cochlear implant, as I said, about 7 months ago in May of last year. And I had it under general anesthesia. It was outpatient, which I was very surprised, but I was delighted at the same time. And as Dr. Zeitler mentioned in his talk, the surgery goes very easily, but in order to get the most benefit, there is a fair amount of rehabilitation that the patient has to do to get the most benefit out of it. So let's go through the questions here. I'll read the first one. There's one from Michael Ricklets. He says, Dr. Zeitler, I have hyperacusis. How does this weigh into the cochlear implantation process and outcome?
Sure. Thanks for your question, Michael. So hyperacusis, it in some ways is kind of thought to be in the same family as tinnitus. It's some sort of dysfunction inside the cochlea that's causing sort of an abnormality of processing of sound. The short answer is it doesn't necessarily weigh into the process. In many cases, hyperacusis is substantially improved following implantation because we've bypassed the damaged part of your cochlea that's causing the hyperacusis. And in some cases, as I talked about, if some of the residual hearing that you might have goes away after implantation, that may also help with hyperacusis. So the short answer is it doesn't. Perhaps if one of your ears has hyperacusis and the other doesn't, and you're a cochlear implant on a candidate on either side, again, that may be something that helps determine which side you do, but certainly something to talk about with your surgeon.
Another question we have here is, you mentioned a while back the patient heard the wire being inserted. He was baffled because nothing's turned on at that point.
Correct.
Wouldn't it be more of a feeling than a hearing?
Yeah, it was the most bizarre comment I've ever heard. Question is whether he heard it in his ear or whether he was hearing it literally kind of scraping the nerve, like it was almost like rubbing your fingers on a chalkboard. I have no explanation, but he distinctly said that he heard it. So it was awesome.
Weird stuff goes on in the brain, man.
You got that right.
So we have a couple of more questions here, but I think you can answer both of them together, Dr. Zeitler. First one is, do all manufacturers follow the same protocol as to device failure? And the follow-up question was, how is the placement of the magnet determined?
So I don't know exactly what the question asker means by the same protocol as device failure. What I can tell you is all of the devices fail similarly. Two of the three cochlear implant companies are publicly traded, and so they have to report their data publicly. The third company is a privately held company, so they're not held to the same reporting standards as the other two, although they tend to use the same criteria for reporting failures. But we report these failures in much the same way that the pacemaker industry reports failures. There are very strict definitions of failures. There's something called a hard failure, which means the device itself is broken. There's something called a soft failure, which means the device for electrically seems to be working, but performance goes down. So there are a number of different definitions to that. But yes, the short answer is all three companies report failure and deal with failure the same way. All three companies also will replace a failed device. The second question I think you said was, where's the magnet placed, or how do we determine where the magnet is placed? Mm-hmm. The short answer to that is anatomically, the patient's shape of their skull in many cases determines where we place the magnet. Most of us now are using something called a tight pocket technique, which means we're putting the implant underneath the chewing muscle. We're not actually drilling it down into the skull, which saves time and also avoids complications. And that pocket where we put the implant is typically determined by some suture lines or some lines of the skull where bones fuse. And so we use that to dictate where the implant goes. But there are patients who have specific demands. So I had one patient when I lived in Denver who wore cowboy hats, and he had a very specific place that he wanted his device, because otherwise he wouldn't be able to wear his cowboy hat. So we can sometimes work with patients to a point, but at some point, anatomy does dictate our decision.
I have another one here. He's and experienced sudden sensorineural hearing loss 22 years ago in her right ear, and the CI surgery is scheduled for March. Will I go home with the device on my skull, and how difficult will sleeping be?
So you will not, you will go home with the device under your scalp, which is the implant. You will not go home with the external device or the processor. That is typically given to you or put on at the time of what's called your activation, which usually happens some 1 to 3 weeks post-operatively. Sleeping, again, not knowing how your surgeon will be doing surgery and how they do post-operative sort of bandaging. Most people will put some type of bandage on the head, which can be a little bit uncomfortable sleeping, but I don't request that my patients sleep in a chair sitting up or that they lay on any specific side. I say just get comfortable. So it shouldn't be terribly difficult to sleep, but you may want to sleep, slightly, may want to use an extra pillow for the first night just to kind of reduce the strain on your neck. But it should not be a problem.
Anne also asked the question, do insurance companies cover upgrades to the processors?
Yeah, so most insurance companies will provide an upgrade. I believe it's every 5 years. You are also free to buy an external upgrade whenever you want for cash. I tell my patients that the upgrades it's kind of like iPhones, right? Every 1 year or 2 years, there's going to be a change, but only every 4 or 5 years is the change substantial enough to really justify getting a brand new phone. I think the same is true with these external devices. But yes, your insurance company will pay for new devices every set number of years.
Yeah. So, Dr. Zeitler, I think our friends on the phone or on the call might also benefit in some of the questions I asked you before I went in for my surgery. And one of them was asking you how many such surgeries you had performed in the past, and have had any of them not gone the way you expected. So I think the folks might benefit from hearing your response. I was very pleased with your response. That's the reason I went ahead with it. But I think the folks might appreciate hearing that from you directly.
Yeah, well, I'll answer your second question first. Of course, if your surgeon tells you that they've never had a bad outcome, they're lying, because we've all had bad outcomes. We've had people who didn't perform as well as we wanted them to or thought they would. We've had situations where the anatomy prevented a full insertion, or we've had situations where the anatomy prevented an insertion at all. We've had complications with infections. So everybody has had complications, and I would put up a big red flag if your surgeon says that their career has been perfect. What you want is a surgeon who has few complications. And I think that's the question to ask. You also want to make sure that your surgeon knows what they're doing. And in today's day and age, there are fellowship trained cochlear implant surgeons. And not to say that people out there can't be a good cochlear implant surgeon without a fellowship, but I think if you're in the hands of a fellowship trained cochlear implant surgeon, you know that the standard to which their training was held is a very distinctly identified number of things. How many implants have they done in training? Where did they train? Did they use all 3 devices, et cetera, et cetera? The question about how many implants we've done is also a tricky one, because I feel very strongly, having been in practice for almost 13 years now, that even in the early stages of my practice, I was fairly competent. But I also think that there is an advantage of experience. Most people doing cochlear implants are doing more than 1 implant a week, 2 implants a week, 3 implants a week. So you want to take that question with a little bit of a grain of salt, because if someone is just finishing their fellowship and you ask them, how many have you done? Their answer is going to be 25. But at the same time, during fellowship, they've probably already done 150 or 200. So I think it's more you, Kit, or you, Kelly, have to feel comfortable with the person that's going to do your operation. I think you should not necessarily worry as much about the number that they've done as how good the relationship is. Have they spent time answering your questions? Do they seem competent? All of those things. Are they well trained? I think those are more important statistics to look at.
I remember the biggest question. Everything happened very fast with my evaluation, referral, consultation, and I didn't know anything about cochlear implants really before I got referred. So I did this deep dive into how everything works, and I had all this unprocessed information rattling around in my head before I went to my consultation. And the only question I remember that really made the big difference for me was one that my surgeon, Teddy, asked me. And that screen you shot up there for just a second reminded me of it. He said, "Do you remember an old board game called Operation when you were a kid?" And I was like, "Yeah, I remember hitting that thing and buzzing." He said he was the whiz kid champion when he was a kid at Operation. And I said, "I don't need to know anything else. Let's just get it done."
That's funny.
So this is another good question. Do you feel it matters what type of hearing aid person wears prior to getting a cochlear implant, as long as the hearing aid is in good working condition?
Great question. And the answer is, I think the type of hearing aid matters far less than how well that hearing aid is fit. So is that hearing aid fit to the standards, NAL standards? Is that hearing aid as strong as it should be? Are what are they called? The real ear tests. So is that hearing aid hearing what we want it to be hearing? That is far more important than the brand. So my only strong advice would be, if you're on the road to thinking about cochlear implantation, you want to make sure that your hearing aids are checked by a cochlear implant audiologist to make sure that they're fit as well as they can be.
We have another question here. Is it a problem with surgeons having surgery issues, meaning perhaps they shouldn't be doing this?
I'm not sure how to answer that. The good thing about medicine is we tend to be fairly well self-policed. If a surgeon's doing something and having bad outcomes or having complications that shouldn't exist or at a much higher rate, those surgeons tend to be sort of found out. So I don't think there should be any situation where you're in the hands of a surgeon who shouldn't be doing surgery. But at the same time, it's possible. So I think that's why it's important that you really do your research. You want to find a surgeon who has a good reputation. You want to talk to people like Kit and Kelly, or people in your hometown that have had surgery. I think that's why the CI CAN network is fantastic, because it can put you in touch with other people in your neighborhood where you can share information. I think there is a huge benefit to word of mouth in the cochlear implant community, and I would highly recommend taking advantage of it.
Great. And I think we have one last question, and that is, how long do batteries last? Will the external processor ever be rechargeable?
So the batteries, the lifespan of the battery depends a little bit on the demands with which you place on your implant. So if you're someone who turns the volume way up, if you're someone who needs to sit in, boardrooms and really, really jazz up your implant, then your batteries are going to last less time than someone who may sit around and play Scrabble at a nursing home. So the answer is a little bit variable, but it's probably somewhere in the neighborhood of 2 to 3 days, I think, is a fair assessment. And frankly, Kelly and Kit can tell you better than I probably can. Maybe even less than 2 to 3 days. As far as rechargeable, so the processors themselves are not rechargeable, but there are some of the processors that have rechargeable batteries. Not all companies offer that. So that's a question to discuss with your audiologist when you're picking your device and your equipment. Whether the actual processor you'll be able to just drop in a recharger, the answer to that is I don't know, but it's a fantastic idea.
So my rechargeable, it depends a lot on the maps that you run, the amount
That's
of
right.
power that are needed, the skin flap thickness.
That's
All
right.
plays a part into the battery life. And I know that when I first got mine turned on, I was running some, scan programs, and they lasted 18 hours. And then as I got used to listening, I kept wanting more powerful, louder, less sound suppression on them. And my battery life is down to like 8 or 9 hours now.
Yep.
So
Yep.
There's a lot of variables in battery life.
That's right. And you mentioned this, to answer this question, you mentioned the thickness of the scalp. That's absolutely a factor.
Yeah. So
Excellent.
I got tons of questions. I could keep on going, but I know time is limited. I think that this is going to be a good resource to point people to when they want to ask about what goes on with surgery. So I appreciate it. It was good meeting you, man.
Thanks, everybody, for signing on today and listening to our lead speaker. And thank you also for the colleagues from our colleagues from the ACI Alliance for setting it up. Thank you.
Thank you both. It's a pleasure to be here. Kelly, wonderful meeting you. Kit,
Yep.
Keep up the good work. I love seeing, it's always a pleasure to see my own success stories.
Thank you.
All
Thank
right.
you.
Bye-bye now.
Bye-bye.